As you know, I'm the orthopedic surgeon here. I'm the orthopedic surgeon here at Fatma Memorial, and I have been here once before. The topic that has been given to me is clinical approach to neck pain and back pain. What I'll do is actually to concentrate on the clinical examination rather than the actual management of back pain, which comes in the treatment. And first of all, I'll go through the examination of the neck and then show you a small video as to how the neck should be examined, followed by examination of the back, and then again a small video of the back pain examination. I don't think I'll take very long. Examination of the neck should start with the few prerequisites of examination, which are a proper environment for examination, proper temperature in the room, proper exposure of the patient. A proper exposure of the neck means that the neck should be visible to you from front and behind, from the root, from the base of the skull to the root of the neck. The conventional clothes which we wear here do not expose the posterior triangles of the neck or the supraclavicular fossa or the actual base of the neck, which should be done. So if there is a lady who's got long hair, you need to tie them back so you can look all around the neck when you're doing the examination. Exposure is important. There's nothing to shy away from a proper exposure. If you need a chaperone, that's what you get, but you need to expose properly. Remember, as before, there's always a patient attached to the problem area, so observe the whole patient whenever you're doing it. We observe the neck from front and behind. Shoulders are part of the area which they need to be looked at. There's a picture here which is how to be standing with the patient to palpate the front and back of the neck with the patient seated and the examiner behind. Now the patient should be seated and the examiner should be standing behind the patient with the fingers over the base of the neck and the thumbs over the spinous processes of the cervical spine. Now both the hands, as you notice, are on the trapezius. The anterior part of the fingers are reaching the supraclavicular fossa. The index finger is in line with the sternocleidomastoid, and the whole of the palm is on the trapezius muscle. This is one chance you get to assess the power of the sternocleidomastoid. Just as you are standing here examining after you have looked from front and behind at the neck, ask the patient to shrug. When the patient shrugs, you have checked the C4. That's the part of the brachial plexus, which you are going to continue to check as we examine the neck and the upper limb. Shrugging, checking the power of the trapezius. Next, picture on the right. Assess the flexion, looking from the side. The hair is properly tied up so you can see all the cervical spine vertebra, the clothes just enough to cover the patient's dignity, and you can see the root of the neck. You can see the spinous processes of the cervical spine. Forward flexion, ask the patient to touch their chin to their chest. Extension, asking the patient to look up and back as far as possible. Now what I would suggest is not just look from like this one, look from the patient's right side. Remember to look from both sides when the patient is showing you the range of movement with the proper exposure. So this is the right side of the neck. Go on the left side and ask for the same movement to be repeated. You will have a better record of what you saw. Again, examining the lateral tilt of the cervical spine, asking the patient, maybe assisting her to tilt her head towards the left shoulder first and then to the right shoulder. First, I think in our culture, what I do is to actually demonstrate the movement. Come around the front of the patient, demonstrate it to them, then go around the back and then see when they are moving it. A proper instruction is more important than actually looking at it. Assess the lateral flexion, both sides, asking the patient to touch the ear to the shoulders, and then the lateral rotation. The top movement, of course, happens at the subaxial level, and the rotation happens at the atlantoaxial joint. So whenever a movement is happening, if you remember the anatomy as to where the movement is happening, you won't miss. If there's for example, lateral rotation is restricted, you would be concentrating on the atlantoaxial joint, or you'll be concentrating on the sternomastoid muscles that do that. Neurological examination comes next. Begin the neurological examination of the upper limb by examining the motor system. Why I say motor system is because the most positive outcome would be from the motor system. Sensory system has to be very acutely done. Patient has to be very sensitive and intelligent to tell you the sensory system is fully intact. Again, the tone of the muscles, which again comes in the neurological examination, is not really a hard indicator of neurological assessment. So what I would suggest is assess the motor system, but don't forget the reflexes of the upper limb when you're doing the upper limb examination. Now the examination, the trick to that is to actually ask the patient to assume a movement for the muscle you want to check. For example, if you want to ask them to abduct their arm to check the deltoid function, you position the arm in abduction and then try and undo it. If you ask them to abduct the arm when it is not yet done, that's more difficult for them to understand. So assume the position where you want to check it and then try and undo it. That's the trick to examining the motor system, and easier, followed by check the tone and the reflexes and sensations. Now when we're doing the muscle power, as we are going to examine the motor system, what I would suggest is to keep this muscle grading in your mind, which I think most neurologists would do, and anybody who's examining the neck would have this in their mind as to what is the power of the muscle when you're examining it. It's very simple. When there's no contraction at all, it's of course 0. And there's only a flicker of movement, no actual joint movement, that's grade 1. When the gravity is eliminated, I'll give you an example how the gravity can be eliminated, then you can still move the muscle. When the gravity is present, that is grade 3, and grade 4 is further subdivided. You don't have to go into that, but grade 4 is when they can perform movement against resistance, and grade 5 is of course normal strength. Now here's an example of what I was saying. The lady is abducting both her arms and she's using her deltoid. Now we know she's using a deltoid. Deltoid myotome is C5-6. So we're checking the deltoid. The examiner is pushing the elbow down. So he's checking the function, she's checking the function of the deltoid. That's the way to check it. Position it first and then try and undo it. It's beginning with the shoulder. That's abduction. We have checked the C5, which is intact. Again, another C5 way is to check the adduction. Position the arm in abduction, adduction, a deduction, and try and undo it. So the pectoralis major will be checked. Again, C5 will be checked. Here, biceps examination. It checks the extension initially. Elbow extension. Lady is trying to extend it, while the examiner is trying to stop her from extending. So the triceps is being checked. C6 and 7 is being checked. And the picture in the bottom left, the lady is trying to flex it, but the examiner is not letting her flex it. So we check C5, 6. Here on the right, the lady has extended her wrist and she's maintaining extension on the right, but the examiner is undoing it, so we've checked the wrist extension. Here, wrist flexion. You flex the wrist, the patient flexes the wrist and you undo the flexion. Here again, finger extension. Extension is being maintained by lumbricals. The examiner is trying to undo the extension. That checks the C8. Further down, check the T1. So the whole brachial plexus has been checked by these 6 or 8 movements which the patient has done upon your instructions, and you have cleared through the brachial plexus. Here it is the grip, the flexion. The patient has flexed and is holding on to the examiner's finger while he is trying to come out of it. Again, thumb abduction is important because again checks the C8, T1, and finger abduction again checks the T1. The patient is abducting her fingers and the examiner is trying to undo it. We've done through the whole of the brachial plexus by this motor examination. Elicit the reflexes of the upper limb next. I'm sure you know what reflex it is. This is the elbow, it's a triceps jerk. There is the biceps. Yes, you do. You flex the arm to 90 degrees, support it with your left arm, with your hand under the elbow. The hammer is hitting the triceps tendon. Here, the elbow is flexed. There's a thumb on the biceps tendon. The hammer is hitting the examiner's thumb to check the contraction of the biceps. That's the biceps jerk, and then there's the brachioradialis jerk. The brachioradialis tendon over the radial styloid is being held by the 2 fingers and the hammer is hit on it. So these are the 3 jerks with their respective myotome values, C5-6, C7, C6-7 and C5-6 again. Now, assessing the coordination of the upper limb, you need a very intelligent patient, but the coordination again does come in the neurological examination of the upper limb, but hasn't got a great importance examination of the neck. What I would suggest is to do some sensory examination as well, if you do remember the sensory chart. This is a sensory chart as to where the cervical spine dermatomes go. Starting from C1 at the back, C2 is the neck, 3 is the trapezius area, 4 is the shoulder, 5 is the outer arm, 6 is the thumb, 7 is the middle finger, 8 is the little finger, and T1 is the axilla. So the whole brachial plexus. Sensory charting you can do if you remember the chart. This cannot open the file. It's in the USB here. आप इधर आएं ज़रा इसको लगा दें. I detected before that the video will play, but we can go through further. Which I want to talk to you about is the cervical spine X-rays. As to the basic indications of cervical spine X-rays, I wanted to include this in my previous talk when we talked about X-rays, but I missed out on it, so I thought I'll bring it now. As to what are the essential indications of cervical spine X-rays. In somebody who sustained a multiple injury or a high energy trauma, somebody with head injury and is complaining of neck pain, somebody who's unconscious, somebody who's sustained a hyperflexion injury or extension injury with neck tenderness over the midline. This is the patient who must do a cervical spine X-ray, who's unconscious and maybe has had an injury. Now, cervical spine X-ray, there are certain mandatory views of the cervical spine, which, of course, I would say are essential and are part of the trauma series when somebody is presenting with multiple injuries. Lateral, including C7 to T1. This is most important because the X-ray has to be adequate to be judged. If this T1 is not visible, you really can't make up your mind whether the cervical spine X-ray is normal. That's why we need a swimmer's view, which brings up the junction of cervicothoracic area, C7 and T1. Another mandatory view is an AP view to check the main stability. And then the third one is the open mouth odontoid peg views. This checks the odontoid peg and the atlantoaxial junction. That's where I said the lateral C-spine is part of the initial trauma series. Now, looking at a cervical spine X-ray, there are a few points I want to make. If you see a cervical spine fracture, any fracture anywhere on the cervical spine, 50% will have an adjacent level injury. 16% will have a fracture at another part of the cervical spine. And 9% will have a thoracic or lumbar spine injury. It's quite a high percentage for not screening the rest of the spine. So that's what we do. If there is a cervical spine fracture on a secondary survey, the rest of the spine is either X-rayed or examined. And I think you will like this part of my presentation, how to read a cervical spine X-ray. If it does come up to you that there is a cervical spine X-ray, remember the ABCs as you've done in the trauma thing, is ABC and S. The first is the adequacy of the X-ray. That is the X-ray adequate? Is it including all the areas you want to look at? Is the general alignment of the vertebra normal as it should be? Second, you look at the bone, the quality of the bone, the outline of the bone, the density of the bone, then the cartilage, including the intervertebral disc, and then the soft tissues. These are A, B, C, and S of any X-ray actually, but concentrating on the cervical spine, looking at the adequacy, whether the X-ray is adequate. The lateral view should include the T1. When you're looking at it, if the T1 isn't there, you can't comment on the X-ray. And it includes the area from the occiput up to the T1. The AP view is symmetrical, that means there is no rotation, looking at the pedicles, and it also includes the vertebra from C1 to T1. As far as the open mouth adequacy is concerned, it should be neutral, not rotated, and shows the peg in full. The peg is the vertical process of the axis vertebra. Now here's an X-ray where I am trying to explain how to look at an X-ray. Now these are 4 lines, there are 4 lordotic curves in the cervical spine. This is a lateral X-ray. This first line is at the front of the vertebra, the second is at the back of the vertebra, the second line is at the in front of the spinal canal, then the third line is behind the spinal canal, and the fourth line is over the spinous processes. Now any cervical spine X-rays, if you trace these 4 lines on the X-rays, they should be symmetrical, there shouldn't be big steps in them. And then the measurements come after that. If you're happy with these general alignment, the alignment is fine. Then we go to the bone after this. This says 12 millimeter, that's the spinal canal. That's the minimum diameter of the 12 millimeter, which you would expect in the cervical spine. Now coming to the bones, symmetrically I would trace around each bone, look for lucencies in the bone, especially in the odontoid. You can have an cyst in the odontoid peg, and you measure the pre-dent space, the space in front of the odontoid and behind the arch of the atlas. It should be less than 3 millimeter. Then they compare the anterior and posterior vertebral heights, looking for compression fractures or displacement. And the facet joints, which are the joints behind the vertebra, in between the vertebral pedicles, they should be parallel to each other. Then look at the spinous processes. Lastly, the last curve at the back, if there are any avulsion fractures, any abnormality there. If you do this stepwise, you won't miss anything. You do the 4 areas systematically. Now here, just to revise your anatomy, this is the spinous process. This is the posterior wall of the spinal canal, anterior wall of the spinal canal, the anterior wall of the vertebra. 1 curve, 2 curve, 3 curve, and the 4th curve is at the back. This is the lateral view again. 1 curve at the front, 2nd curve, 3rd curve here, and 4th curve there. This is the facet joint. This is transverse process with the facet joint, top and bottom. Now lastly, looking at the soft tissues. On a lateral C-spine, the intervertebral disc is the first soft tissue you look for, cartilage and soft tissue. The space between the 2 vertebrae should be symmetrical and should not be reduced compared to the vertebrae above and below it, and it should not be tilted more than 11 degrees. This is a rough calculation, but if you're looking at the disc, you measure the distance between the 2 vertebrae above and below, and then compare the one you are looking at. Then the prevertebral soft tissue, the swelling, the soft tissue in the retropharynx, especially at the level of C3, should not be more than 5 millimeter. If there's a fracture of the vertebra, there will be bleeding, and the anterior soft tissue will be increased. At the level below the larynx and at the level of the larynx, the soft tissue swelling should not be more than the width of the vertebra. Now here, this is just an X-ray of the cervical spine which I got hold of. There is a pathology in it, but this is I'm trying to demonstrate to you what you should look at. Is the X-ray adequate? Is the alignment okay? What about the bone? What about the cartilage? And can you see the soft tissue? All those 4 things, if you remember them, you'll be fine. Now this is the anterior lordotic curve, the middle lordotic curve, the anterior wall of the spinal canal, the posterior lordotic curve, posterior wall of the spinal canal, then the spinous processes. 4 lordotic curves, they're all symmetrical. This is more lordotic, more convex cervical spine compared to normal, because it has got a bony pathology in it. This is the first vertebra, atlas vertebra there. This is the axis vertebra with the dens above it. This is the 3rd cervical spine vertebra. The pathology is in the 4th, 5th and 6th. See, the disc spaces in between 4th, 5th and 6th are abnormal compared to the disc spaces above them. There's a congenital fusion, synostosis of the vertebra at the subaxial level. So that's what the pathology here is. Quality of the bone isn't bad, it's quite good quality. There's no displacement antero-posteriorly. There's a little step off at the line, anterior spinal canal line here, because this is a fixed segment, this is a mobile segment. So when we do the flexion extension views, this segment will move forward and this will stay where it is. Flexion extension views and additional views to check the stability of the cervical spine. This I brought just for an example. Next we go on to the examination of the back. I'm sorry about the video, and if you can wait a few minutes, I can get the CD with the video from the car, because we'll miss out on it. If you think about the questions about the cervical spine, I'll quickly go and get that CD which contains the video. the examination of cervical spine, you first do look at the temporomandibular joint, because that's again a connection of the skull with the bottom. So asking the patient to open their mouth and feeling any crepitus. Then a proper exposure, front and back. Voice still easy? नहीं चल रही, कोई बात मेरी सुनिए. The full exposure, front and back, to the root, from the base. Next is asking the patient to stand with the neck relaxed forward, feeling the cervical spine vertebra from C1 to C7 for any tenderness. Feeling the trapezius muscle for any spasm, tenderness or pain on palpation of the rhomboids, the levator scapulae, and then the rhomboids, the interscapular muscles. Right? The interscapular muscles extend up to the bottom of the scapula. Looking at the neck from the front, asking the patient to flex forward, looking in the profile of the cervical spine at full flexion, looking to the side, checking the sternomastoid functioning, full rotation to the right, full rotation to the left. This is mostly happening at the atlantoaxial joint. Lateral tilt happening at the subaxial level, asking the patient to check the ear to the shoulder, this side, ear to the shoulder, checking lateral flexion. Extension, asking the patient to look up and as far back as they could, examining it from either side. So that was the examination of the neck, cervical spine, and the brachial plexus. If not, then I'll just carry on. Now, examination of the back again starts with as much exposure as you can get, and the initial examination, of course, is look before you feel. So, you're looking at the patient standing from behind. Observe the patient as a whole, front and back. Ask the patient to stand in the middle of the room, go all around the patient, examine from the sides, front and back. Once you've done that, the next step is to ask the patient to walk on their toes. This will, of course, check the power in their flexors of the knee and the flexors of the toe. You will check the sciatic nerve. We were at this step in which you ask the patient to walk on their toes, and then you ask the patient to walk on their heels. This is the beginning of the examination of the back. The picture on the right shows the extension at the lumbar spine level, and asking the patient to extend while they are standing. There is a measurement involved in bony excursion when the patient is flexing. With a measuring tape, 2 bony landmarks on the back are measured, and then the patient is asked to flex, and that area is measured, indicates the amount of flexion at the lumbar spine. This is back flexion. The picture on the right bottom shows the patient is fully flexing forward, and the examiner is sitting behind. If there's any hump on the ribs because of scoliosis, it will be apparent at this angle. Lateral tilt, again, asking the patient to drive their arm down the side of the leg on either side and looking at this spinal curve as it is produced. Measurement, it should be minimum of 5 centimeters when the patient is flexing. So 2 bony landmarks before flexing, and then when the patient is fully flexed, the distance traveled between the two should be minimum of 5 centimeters. That's normal flexion movement at the vertebra. There's an example of somebody who has got ankylosing spondylitis, and he's got this thoracic kyphosis. He is, of course, not going to have any forward flexion movement. What to talk of 5 centimeters? He probably will have less than 1 centimeter forward flexion bony movement. Very little lateral tilt and very little rotation. Asking the patient to do rotation by stabilizing the pelvis first, and the top of the body is turned to one side, checking the rotation. Here is a test which is used to differentiate between the pain in the lower back and the hip. Flexing, abducting, and externally rotating the leg will produce pain in the groin. If the problem is in the hip, will produce pain in the back if the problem is at the back. Straight leg raise, very commonly done test, and then its aggravation by dorsiflexing the foot at the left bottom. Hip extension and passive flexion to check the femoral nerve stretch signs. This is a sciatic stretch test on the left, Sciatic stretch with the dorsiflexion enforced and straight leg raise. This is patient prone with the hip being hyperextended, knee flexed to stretch the femoral nerve. This is a femoral stretch, sciatic stretch. Again, in the neurologic examination of the lower limb, checking the power of the quadriceps, the knee extensors, holding the knee, foot there, and asking the patient to extend it. Asking the patient to flex it while you are trying to stop her from flexing it. Knee jerk, slight flexion at the knee, hitting the patellar tendon, contraction in the quadriceps. When you're doing the knee jerk reflex, the quadriceps should be exposed. All the close up till here will miss out a small contraction in the quad if you don't see it. So a reflex jerk contraction should not only be felt but seen as well. Again, ankle jerk reflex, hitting the back of the tendon Achilles and feeling it, looking at the contraction there. Sensations in the sole of the foot, fine sensations. As I said, they are a very crude way to identify neurological deficit in people who are not very intelligent. There's one test I'll give you for a malingerer. Somebody who's complaining of neck pain and to rule out whether the pain is genuine, press on their head. And if they say it is painful, then they're lying, because there's no pain produced by just vertically pressing on the head. Back examination का वीडियो लगाने वाला curve, the lumbar lordosis in the profile, looking it from the side and then looking it from the back. The straight line, the plumb line, if the line is straight, asking the patient to bend forward. This is the time to look at the hump on the rib and looking at the flexion. See, as he flexes, the lumbar curve straight flattens out. This forward curve, now it is flat. And the movement between the two vertebrae. This is a normal gentleman, so the forward flexion is being tested on him. Next, if you want to check the rotation, you stabilize the pelvis with your hands, holding the iliac crest on either side, asking the patient to tilt on one side. The thumbs should stay level. As long as they stay level, the movement is happening at the lumbar level. So that's the cervical. You look at the curve every time it is produced. Back extension, still holding on to the pelvis. How much back extension he can produce. Lateral tilt, lateral rotation, the top part, where these should stay where they are. Otherwise, the rotation is mimicked by the hip rotation. Next is the palpation of any tenderness on the vertebra. You've done the neck examination. Now she's continuing down the spinous processes of the thoracic spine, the thoracolumbar junction, and the lumbar spine. Feeling all the vertebra stepwise, and then feeling the intervertebral space as you jump from one to the other. Any increase in the space, any prominence of the vertebra, any tenderness, and any abnormal movement there. Then feeling the erector spinae muscles on either side for tenderness, spasm on the part of the patient, working from below upwards up to the thoracic spine. Thank you. Next one. Thoracic spine X-ray. This is part of the segment of the thoracic spine X-ray. But the things to look at again are A, B, C, and S. Just giving you an example as to how to look at a thoracic spine X-ray. If it is symmetrical, the supraspinous processes will be in the middle. See this dense shadow in the middle? If it is symmetrical, they will be in the middle. Okay, this supraspinous ligament shadow, or the spinous process shadow, is in the middle. Next, you look at the vertebral height. One vertebral height and the other vertebral height. Measure it actually to see if there's any difference. Then you look at the shape of the concavity on either side of the vertebra. Then the end plate. End plate is the area where the disc is, where near the vertebra. If there's any reduction in the disc space, then the costovertebral junction. These are the ribs coming on to join the vertebra on either side. And the lastly are the soft tissue shadows around it. Are the soft tissue shadows normal? This is a hard shadow, so are the soft tissue shadows normal around it? There's a lumbar spine X-ray, and I've drawn some lines to just to explain what I want to say. This is a lumbar spine AP view. Is it symmetrical? Yes, the spinous processes are in the middle. The pedicles are on either side. So these are the two eyes and the nose in the middle. So if these faces are symmetrical, coming from top to bottom, the X-ray is in proper alignment. Whether it is adequate or not, how much you want. You want L1 to L5, and then you want a lateral as well. So looking at just the alignment, this is one line which connects the top pedicle. This is a facet joint pedicle, one line joining the top pedicle to the inner border of the bottom pedicle. If it touches the pedicles in between, then there's no abnormality in these vertebrae. If there's a compression fracture, for example, the pedicles will move away from each other, the vertebra will be widened, and this line will produce a step off here. The vertebra, this ring will be here, the eye will be away from the middle. These are the lines, imaginary lines you draw on an X-ray to look at the symmetry. This line is pointing to the spinous processes at the back. This is the facet joint, the pedicle, this arrow. This arrow is on the transverse process. So all the bony landmarks are identified and looked at. This is the iliac crest. So if the anatomy is, if you are familiar with the anatomy, stepwise look at all the structures, the vertebra, the intervertebral disc, and then the soft tissue. Here is the soft tissue is important in the lumbar spine to look at the psoas shadow. The psoas, which comes from the transverse process of the lumbar vertebra, is very frequently produces abnormal shadowing. If there's any, for example, a tuberculous abscess or a renal stone, you can see it here. The ureteric stone. There's the lateral view of the lumbar spine. The arrows again pointed. This is the pedicle of the lumbar 3 vertebra. This pedicle. This is the intervertebral foramen between the lumbar 4 and lumbar 5. This is the spinous process of lumbar 4. The alignment again. The line in front, the line behind, and the line in front posterior to the canal, and the line over the spinous processes. Well, there's a huge list of differential diagnoses of back pain. I don't know whether you want to go through that, but I've just written it anyway. Spondylosis, spondylolisthesis, which is instability in the spine, or actual displacement of the spine, spondyloptosis. Infection, discitis or vertebral body in tuberculosis, for example. Malignancy, primary or secondary. Loss of limb, pathological fracture, dish, idiopathic skeletal hyperostosis, nucleus herniation, heterotropic ossification, kyphosis, scoliosis, fractures and dislocation, osteoarthritis, dysplasia, rheumatoid, ankylosing spondylitis, spinal stenosis. All of these will cause back pain. And I think my time is up. I'll answer your questions if you want.